So good afternoon, everyone. I'm Lisa Kachnic, and I'm a radiation oncologist, and I've been asked to speak about artificial intelligence and its promise for the next 50 years for treating our cancer patients. So before we begin, we have to start with some basics, and I myself had to learn these basics. So what does artificial mean? So it means not organic, not inherent, made by machines and made by computers. So what do we mean by intelligence? At the most basic level, we think of intelligence as the ability to take in information, interpret it, and respond to it. But at the highest level, and probably what makes me most excited, it's the ability to create novel ideas, new paradigms, and really to ask, what if? And something my parents always said, break rules and go beyond the boundaries of possibility. So I know everybody knows Jeopardy, but does everybody remember in 2011 when IBM Watson was a player? He's the middle person. I know everybody knows Ken now, because Ken's one of the new co-hosts for poor Alex Trebek, who died of pancreas cancer a few years back. But in 2011, we had IBM play and beat the world's best quizmasters in trivia. But cancer care is a little bit different. It's really more complex than a game of Jeopardy. With Jeopardy, Watson had the perfect scenario. The question-answer format is specific and defined. One answer per question. But all Watson really needed was a lot of information to crunch, and through all of the data, they'd be able to get one answer, the likely answer to the question. Cancer care, on the other hand, is far more complicated and nuanced. While AI does a really good job analyzing quantitative data, such as your lab results, it has a much harder time taking data, very nuanced data from a patient's chart that is rich in psychosocial information. Cancer care is also constantly changing, and it's constantly evolving. Data from many, many years ago, and even 2 years ago, is far less relevant today because we have new drugs, we have new technologies such as radiation, we have new molecular discoveries that have all been found. So just thinking about Jeopardy again, when there's a couple of possible multiple answers, here we have multiple treatment choices, and then choosing the correct one often takes into play a whole nother level. For me, example, it's taking the hand of my patient and having a long conversation about what are their goals of care and what's most important to them and their family members. And this is why Watson for Oncology hasn't yet delivered. But I'm not trying to be Debbie Downer here. I think I'm hoping to show you that the possibilities of AI are endless and even now quite exciting, because today we can use AI to really augment our ability to diagnose and treat patients along the course of their care. So at Columbia, and I was hoping he'd be here with me, but he isn't, but I'm going to speak to what my radiology colleague and friend, Dr. Larry Schwartz, is doing. And he's actually applying AI to standard of care imaging, which you can see on the right, to help predict how well patients with cancer may respond to treatment. So he and his team, and we have some in the audience right here, developed a machine learning algorithm that analyzes a patient's CAT scans as a method to create a biomarker or a radiology or radiomic signature. And that actually correlates with patient outcome. In this case, and you can look at the right panel with the 2 CAT scan images, the signature can predict which patients with metastatic melanoma, in here of the liver, will respond to immunotherapy. The goal here is to take predictive information and optimize an individualized care plan for each patient in real time, and tailoring that plan to the patient's individual biology and health goals. Our future hope, especially as applied to radiology, is taking this signature to predict cancer before it even begins to show symptoms, allowing us to treat that cancer at its most vulnerable early state when a chance of cure is at its highest. So I've shown you how AI, or machine learning, is really well poised to make a big impact in radiology. But what about the power of AI for what I do, radiation oncology? And for those of you that don't know, that's actually treating patients' cancers with very high doses of these same X-rays that are used by radiology to produce a diagnostic image. And in my field, we're just at the tip of the iceberg with AI. So this is taking me back to my residency, also at the MGH. I think we have a lot of people here in the first row that have been there at one point or another. And I don't want to age myself, but I will. When I trained, I guess in the Stone Age, this is what I did, this picture right here. I took a two-dimensional fluoroscopy that I got myself, image of a patient, looks like a box here, and then with a crayon, although many colors, I had my inner Picasso working, very long crayons, I actually drew the patient's tumor. I couldn't find my old film, so this one I had to take off the web. Mine were more elegant. But I would draw the patient tumor always in red, the normal organs in yellow, and then see those sort of purple blocks on here. That's where we cut lead blocks to prevent those areas from getting any radiation. But what happens is we treated the normal organs to the same high dose that the tumor received. So while we had cures, we also had a lot of toxicity. But we've made some improvements over the last 20, 25 years, and we've gotten much more conformal. We started using a CAT scan, and this is three-dimensional fields from that. We still treated a lot of normal organs, but we knew how much dose they received. And then we went to actually doing this very fancy arc therapy called intensity modulated radiation, which more paints the dose to the tumor, and the normal structures are less involved, so side effects were going down. But I'm really excited because we've started using an AI-enabled machine called the Ethos that incorporates machine learning into delivering radiation for our patients in even a more precise and targeted way, potentially allowing us to treat the tumor more aggressively, which hopefully further minimizes the impact to the surrounding normal structures and decreases side effects. So again, the goal here is really more cure, less side effects. Right now, when a patient presents for radiation therapy, we make a treatment plan that takes into account margins of error in terms of targeting their tumor, margins for cancer cells we can't see, microscopic disease, and then margins if their body changes throughout treatment, such as they gain or lose weight, or even if they have a full bladder, a full rectum, or a full stomach. And creating this map or plan is very labor intensive. We don't have the manpower or resources to recreate it every day for a patient when they come in for 25 plus days of treatments. But what if we could create a new plan for every radiation treatment based on how the patient presents that day? We could safely increase the dose of radiation to the tumor, reduce that extra margin, and still minimize the amount of radiation even more going to the surrounding normal organs. And this is where AI comes in. AI has that computational power to do all this in minutes. And the busy work usually takes us about 5 to 8 days right now. So again, with Ethos, we take this quick CAT scan. I'm going to show you a picture of the results of the patient before we start treatment, while the patient is right on the treatment table or the treatment machine. And as soon as that image is acquired, machine learning algorithms start chugging in the background to detect any changes in the patient's physiology on that day on that table. It could be changes such as they had a big breakfast and they have a little too much gas in their bowel. And then the algorithm starts redelineating the normal organ and all of the normal organs and the tumor, and then sort of automatically pops up with myself or my colleagues on the console the whole time. And then we make adjustments to those structures, and then poof, a new treatment plan comes up. We review the plan. Usually it's better and we choose it. For example, don't know if it came out so well, but if we went with sort of the old plan from the original treatment, this is what we call a big cold spot in the middle of their tumor, which is in red here. And you can see with the adaptive treatment, it's super homogeneous, and I know it's getting like a super good dose. So then I choose that plan, and it's amazing because all of this happens while the patient was there from start to finish in less than 20 minutes. And when they go for their regular treatment, it's going to take that amount of time anyway. So again, with each day, they get a personalized treatment plan, and we're able to truly tailor that treatment to the patient, not merely adjusting the patient to match our initial plan. But what if we could incorporate even more data into that initial treatment plan, giving us insights on how to better treat that particular patient's cancer from day zero, the moment they are diagnosed? And what if we could sift through terabytes of multi-omic data, just like all of those nice slides you saw before, their imaging, the radiation information, to predict how a particular patient will respond to all of their treatments at our fingertips: chemo, immunotherapy, surgery, radiation, many, many more, and the optimal order of those treatments. And what if we could take all of that rich data and develop a dashboard of sorts, predicting not only the best treatments for the cancer patients, but what if they would develop cancer at all? So I think at this junction, and again, thinking about 50 years and 50 years, we're both very close, but we're still far away from this reality. I think the real issue is, if you just even look at the sort of cartoon here, there's just so much data, and that data is so complex. And cancer care, again, is not like Jeopardy, where there's a simple question and answer. Further complicating this whole issue is the fact that health data we are generating is both flawed and disparate. Healthcare systems across the US, although many are moving to Epic, many still have different electronic medical records, and the systems still don't talk to each other. Further complicating this is privacy policies in healthcare. Although they're very important, they limit the amount and type of data that can be collected and shared. If the data universe cannot be integrated, we will stay where we are now, with individual health systems, corporations and companies attempting to make headway in this AI space in their own silos. There's also a question of trust and adoption of AI. The stakes in cancer care, again, are much more greater than in Jeopardy. And there was actually a study of AI-generated radiation plans, just like the one I just showed you, in Nature Medicine a few years back. And radiation oncologists considered that the vast majority of these AI-generated plans, 89 of 100, looked pretty good. But when it came time to sort of say, okay, am I going to use these, only about 60% said they would. Are we correct to be distrustful right now? Maybe. A 2019 study found that an algorithm widely used in the US hospital systems to allocate health care to patients was systematically discriminating against people of color. The fear that AI or machine learning can really exacerbate racial biases is very real. So how do we overcome all of these challenges and deliver in the next 50 years on the promise of AI in cancer care? I think the answer is I wouldn't say it's simple, but it's radical. We actually need to break down the walls and have transparency and communicate together. And I know this seems like a big thing, but we've had practice. We just got through the worst part of COVID, and we broke down, or all those traditional silos came crashing down within a few months. This isn't a space race. I think we will get there, but one institution won't solve the issue on its own. We have to really work together to make this a reality. Now I want to swing back to our patients. We really need to do it for our patients, and especially, just like Dr. Sharpless said, for our patients who don't have access to care, who don't have access to great academic institutions like Columbia, where we have a network of specialists, not just here in New York, in our own backyard, or in the US, but we need to do this across the globe, because that's where the real promise of AI is. It's providing that best quality of care to every person, no matter where they are across the universe. And being able to take all of this data at population levels and pinpoint the exact treatment plan, just like we do in radiation, that will work best for every single patient. Thank you.